So appreciate all of you all, being up here today, and looking forward to a good conversation. I think I'll kind of kick us off, and you guys just hop in. You'll all have a mic. Just give some insight into kind of what you're thinking or your opinions on the state of healthcare in Eastern Kentucky. And inside of that, obviously, workforce is something that's at the top of mind. I'm interested in how you're looking at reimbursement rates and some of those things that at an executive level, and then just general trends for rural hospitals and facilities to begin with. So, Barry, I don't know if you want to start. Donovan, is your microphone?
I think I got it.
Okay, all right, just making sure. But yeah, just general thoughts on the state of healthcare in Eastern Kentucky, and whoever wants to hop in first.
I'll defer to the hospital CEOs first. So, state of healthcare in rural America is not any different than it is state of healthcare in Kentucky. It's state of healthcare is improving in regards to access to employees, access to care. I think we had the lull through the COVID era where we had challenges with employment, with getting people, with keeping people. That has improved. Are we over that hump? No, not by any means. We still have a large struggle in getting employees in and keeping the employees that we have. However, it has improved greatly just over the last 12 months. As far as reimbursements and things, that's an issue both on the national and the state level. State level, we have the HRIP, which we have as a sub-support mechanism today. But that's something that's on the table and voted on annually. So we have to really push for that, as well as CON protection, which is something we've battled for years, and we will continue to battle and hopefully win.
I'm just going to echo what Brian just said. We had kind of the conversation before we came up here discussing some of these same matters. And I can't remember the word you used a moment ago when we described weird.
Weird.
Yeah, weird. State of healthcare is kind of weird, and what I mean by that is that when you look at pre-COVID, from our perspective, we were kind of finding our niche, making smart investments. Payer mix within the region, especially in the rural areas, is always going to be a struggle because of the nature of the beast and where we serve, who we serve, and what type of facilities we tend to have. So that's going to be an interesting issue to deal with going forward. But HRIP, and I certainly give this administration great credit, because when you look across the nation, hospitals in Tennessee, for example, 40% are at risk. If you looked at the number of hospitals that would be at risk in Kentucky without HRIP, it'd be a number that I would be afraid to mention right now, including those of us that are up here. And the reason why that's important is because after coming out of COVID, and why that Brian's saying that it's stable, is that hospitals, as you mentioned, and that's what you get when you let PR and marketing write your bio, by the way, is all those nice things that they say about you. But in dealing with the different organizations, what we find is that everybody has the same concerns and the same problems. And whether it's cutting back on services during COVID, whether it's dealing with the workforce development issue, whether it's dealing with CON issue, which we're going to spend an absorbent amount of time probably through this next session, trying to protect rural hospitals, and that's where the distinction is. So when you look at the state, with HRIP, especially in Kentucky, it's allowed us to continue to prop our services up, continue to even expand in some cases, leveraging some of the federal and state support programs for investment. We've gotten a lot of grants that we're able to make these investments in. But without HRIP, I think it would be a totally different story in Kentucky.
Could you, Donovan or Brian, they were talking about HRIP to me earlier, and I thought I was looking at my heart like something was wrong with it. Can you just define kind of a little bit of what that is and kind of why it matters to people in Eastern Kentucky, for example?
Sure. HRIP is an advance payment, in essence, through Medicare, through CMS. Both the current administration and the legislators worked very hard to make that happen. But it started based upon an increased rate for your inpatient services, and then it grew to outpatient services as well. And it's also tied to quality matrix, which is going to be a big piece of this going forward. So what the federal government said is they're looking at Kentucky at your quality matrix and the type of patients that you have. Again, when you look at both PMC and ARH, our payer mix, we run almost equal, about 77% Medicaid, Medicare. So looking at your payer mix, the reimbursement, being in a rural community, also tying something to quality is important to improve the overall quality that the patients receive. So what we've seen since that time is that the matrix that they have put in, Kentucky has really excelled in and will continue to do so. So as we go forward, assuming those rates continue, we'll see more and more of the reimbursement tied to quality. So we lose money by not meeting certain criteria or meeting certain quality matrix. That level or amount will continue to grow next year and then the year after that.
And ultimately, this is important too, because with these rates in place, you guys are able to maintain service lines, definitely not close, but maintain, potentially expand, which means you're able to hire more, keep more staff, which is more people on the payroll, more people in communities. There's a lot of ripple effects that come with how you guys are able to keep things running.
Yeah, and HRIP is Hospital Rate Improvement Plan or Improvement Project, depends on which way you looked at it. But the HRIP dollars are federal dollars actually that are allocated by the state. So it's one of the things, and everyone here should be proud of being a Kentuckian for, because it's other states didn't allocate it the way in which we did, and those states are struggling. Yeah. And we actually got it right, which is good.
Barry, I mean, I know you deferred to your hospital partners, but how about you answer? I mean, you've been involved with the Primary Care Association. You've got your finger on the pulse of, from the aspect of primary care providers. I mean, talk a little bit, build off what they said, kind of where you guys fit into that ecosystem, and would you still use the same word as weird to describe the state of primary care facilities?
Yeah, I guess weird in the sense that, cost has increased dramatically with COVID. From the end to the beginning to the end of COVID. And for rural health clinics, FQHCs, I can only speak for rural health clinics from my standpoint, our reimbursements have not changed. They've only increased based on the Medicare Economic Index. So it's made us become more efficient and leaner from our standpoint. We're still having the same problems as the hospitals with employment, with adequate staffing. We're in competition to a certain extent for the same nurses, lab, X-ray. So, from that perspective, we're in the same boat. We're all vying for a fixed amount of employees, and we're trying to enhance that through education and recovery, second chance recovery with substance use disorder. I think that is probably our next untapped source of employees because, Donovan and I have the pleasure of sitting on the SOAR board, and we talk about issues that plague Eastern Kentucky, and that is one of them, is employment and having enough willing bodies to work. But I think we are working closer with Medicaid and the MCOs, the managed care organizations, to try to enhance quality, for us to look more at quality indicators. They're trying to reimburse us more for hitting those marks. So we're trying to become more partners in that, rather than being kind of dictated on what our quality measures are. So there is some hope.
Colby, Barry said something important. And oftentimes with sessions like this, we kind of fly through answers because there's so much to healthcare and it's really kind of hard to understand. But there is a very important piece of that. I talk about payer mix. And when you're looking at the region that we serve, especially in rural parts of the nation, and then in our area, when you're looking at what the 77% mean, realizing that this is not free market, right? That 77% of our payment is dictated, in essence, by the state and federal government. And why that's important is what Barry just said, is that when you look at the rate that healthcare providers, especially in rural parts of the state, and certainly in our case where you're looking at 77% of your payment being that way, that the inflation rate was much greater than what CMS is able to raise our reimbursement rate. And then you throw on top of that the workforce crisis, which increased wages to a level we've never seen before. So when you see a 4 or 5% increase in payments, and you see a 30% increase in inflation with supplies, whether it's medicine or some services, and then you layer on top of that what we're fighting with the payroll or the workforce issue. Going into COVID, most rural hospitals are operating on a thin margin anyway. So this is what has made this weird, is that we're dealing with something that we've never dealt with before, and without the federal government stepping in, especially recognizing that quality is important, but also we're going to have to prop up some of these areas, because then you look at the part of the region that we serve, which is being highlighted here today, in that we serve the sickest of the sick within our service area. So we lead, unfortunately, the nation in pulmonary disease, heart disease, cancer rates, diabetes, all these different things with different comorbidities. And what's, I won't say aggravating, what's aggravating, I guess, to folks like us is that because of the comorbidities, you also get dinged if your readmission rate exceeds a certain rate. So you see patients coming back in because they can't help it. So it's a very complex business and model, but that's why we sit up here and say that things have gotten back to some sense of normalcy, simply because what this administration recognized and has done, working with the federal government through CMS, putting the importance on quality, while also recognizing that right now that there's 19 states, I think, in the nation that's looking at Kentucky, how and what we're doing, asking for some of those same considerations because of the state that they're in. So we should not overlook how blessed right now is probably the best word to use that Kentucky is, even though it's a struggle.
Whenever we talk about finance and hospitals, and I'm talking to a group, I always use this example because it kind of transcends. When you go into the ER with chest pain, or go to your doctor with chest pain, first thing you get is an EKG. Well, you give that to the doctor. There's a fair amount of risk that goes into reading that EKG. I mean, there's 12 different leads, and I have to determine if you're having any issues in all 12 of those leads, and it comes with a fair amount of risk involved. I mean, it's not a completely conclusive exam, but reading the exam comes with risk. So you're reading that exam, and if you're going to truthfully read an EKG, it takes a few minutes, and you go through the whole thing, and you accept that risk as a physician, and you determine whether this person at that picture in time is having an issue with their chest, and you go through all these things, and you spend this time doing that, and then you go on and do your other thing. That EKG read paid $12. I mean, so it's not you went through all these things and accepted all this risk, and your payment for that was $12. Now, you have many other things in your day that you're doing, but the conception that hospitals and physicians are bringing these vast dollar amounts in and all these things they do, it's just not true. And so when you look at taking care of rural America and the 77% of Medicare and Medicaid that we're caring for, it becomes a challenge. I mean, it truthfully becomes a challenge on how do we navigate the fact of low reimbursements, low payments, and then combine that with higher risk and having to pay nurses more, and the three of us having to fight over the nurses we do have. How do you get through that? And the answer is truthfully, Barry and I partner, and Barry and Donovan partner, and Donovan and I partner, and we all three partner, and we try to work through all these things together, because that's the only way you can do it today.
Well, then you also, we can go back and forth, but I'll throw one last piece in, Colby, is, we're talking 77%, but you also have to look at the region that we serve. That doesn't count the amount of charitable work that each of us do. So you throw that into the mix also. So to your point, is there's a perception out there that hospitals are wealthy, and that's certainly not the case, especially the rural parts of the state.
Well, we're going to go to workforce in a second, but Barry, I want to ask you a question because I think it's related. Can you, from your standpoint and being in the primary care space, and I feel like primary care centers has had this facility with multiple service lines and kind of this all-in-one approach with extended hours. As we've looked across the region, it feels like there's been some other organizations that have started to kind of follow that model. So can you tell us a little bit about like what's going on? Is that some sort of reaction to a workforce? Is that you bring everything under in one roof? You're only having to hire a certain amount of. Is that more workforce driven? Is it what is kind of, I guess the your thinking behind this model and why more folks are going to it? Can you talk about like what's going on there?
Well, I mean, I think the need in Hazard is the same need in Pikeville, same need in Lexington, same need all over, is that, you don't want to have transportation or the access as a necessity or a barrier. You want it to be easy access. So what we have tried to do is make it a one-stop shop to a certain extent, because, just like those of you that toured the diabetes center, getting a retinal scan on a diabetic patient, if the retinal scanner is not there, it's really hard to get a patient to go to an optometrist or an ophthalmologist. So I think the other organizations have seen that the barriers to access is broken down by trying to have as many services at one site as possible. And to a certain extent, we kind of feel like imitation is the best form of flattery. So yeah, I think that's why you're seeing more and more of it.
Well, let's dig into the workforce piece a little bit, because we were fortunate to work with all three of your organizations on a recent grant proposal that really kind of dug into something called the prime age employment gap in Eastern Kentucky, which is the percentage of people that are 25 to 54 years old, so typically your prime working age years, that are outside of the workforce. Nationally, that number is about 80%. For the 12 counties we looked at, which included Perry and Pike and a few others, that number was closer to 50%. So there, if you looked at it on a, as close as you could get looking at the data sources, it was tens of thousands of people that probably in other parts of the country, or if they were in another area, at least more of them, would be working. And so, you're looking at that on our side, and then we're hearing from you guys talking about how you're having to fight for people in skilled positions. So talk about that seeming like juxtaposition and what's going on there between, while we have folks on, what is keeping us from going out and shifting more of them into some of these roles, because, I'm not a healthcare executive, but I think, something like a CNA or a lab tech or a rad tech, those are great door opening positions into the role of health, even if it's not a nurse. Right. So I guess dig in a little bit there about why it seems like we have people, but why it's been hard to transition them into positions in healthcare, for example.
That's probably an hour-long session, really, to get deep into that. But I'll start by saying this, is that you mentioned a key word, which is skilled, in that in our case, it's really getting people into programs that are typically 18-month, 2-year programs to get them the education, the certification needed for them to grow. Part of the problem that you have, again, it's a countrywide problem, but more so in our regions, is that there isn't an abundance of allied health programs that already existed. So the infrastructure is not necessarily available in rural communities. Typically, you find these programs more in the more populated part of the state. We're starting to see that change. Obviously, through our initiatives with Project Heart Healthcare Education around regional training, it was about providing facilities, funding, opportunities, and then creating the pipeline to be able to address it. So I don't think, Colby, from our standpoint, it's not necessarily just the 10,000 people that aren't in the workforce. The problem is how do you provide the pathway to get them into accepting, because a lot of these programs have prerequisites that they're not going to qualify for. They have to have funding to be able to pay for it, because they're so far removed out of school. They don't have Pell Grants. They don't have things to help provide the funding. And then you have to have the more technical type services to be able to provide those services. Now, KCTCS, with all the different locations, have become a partner. They're really starting to step up, as well as forming relationships, as you mentioned, with, from our standpoint, with nursing, University of Pikeville, with Galen in nursing, and then ANU has stepped up both in the technical piece. So, but also to get those schools certified, it's about a 2-year program for them to go in and ask to go through all the process and to be able to introduce those programs. So before, and again, all it's driven by a lot of it by COVID. You saw mass exiting of healthcare professionals and a lot of these different services. You saw more travelers, people going to different parts of the market, out migrating outside of rural areas. So there's a Band-Aid fix right now, but if you look at the statistics and look at where we're heading, that's where I'm probably the thing that keeps me up at night more than anything, is realizing the position we're in today and what the needs are going to be tomorrow, that I'm not so certain we're going to be able to meet those in the time frame that we need to. So we're finding ways to be innovative. So that's why you're seeing more AI type systems. I don't want to get into too much depth of the answers, but there's a lot of things that we're looking at using LPNs and versus RNs in some areas, medical assistants. So a lot is changing in healthcare right now, just simply because of the situation that we're in now. So it's not necessarily just about the 10,000, because I've heard that number several times, and it's not that we don't need to find an opportunity or pathway to get people to work. The problem is, if you look at our region, the question is, what type of work is there? And it's retail or it's trained services, and a lot of that trained services, the infrastructure is not simply there to be able to promote them unless they're coming straight out of high school. A long answer, and probably could get deeper, but just to give you my overview.
And even if you're looking at the trained services side of healthcare, let's say you want to be you want to come be a CNA. Used to, CNAs didn't make enough really to make a living. Today, that's just not true. They make enough where they can make a living. And you can get in there on the train sector, and there's a few programs in the Lexington area. You can go and you can become a CNA in 2 weeks, and really for effectively a $0 amount, because we'll reimburse that if you really want to get technical. But honestly, you have to find out of that 10,000, which one are the intentionally unemployed, which one are the unemployed that want to come to work. That's one problem. And then the other problem is, you can come into the technical side of healthcare, but healthcare is not easy. Healthcare is not for everyone. So you can go be a CNA in a couple of weeks, and you come to work as a CNA, and that's work. It's not unlike going to work on a construction site or anything. It's work. Pulling up heavy patients, taking folks to the bathroom, doing a lot of heavy lifting. It's not for your, I'm 50, I can say this. It's not for your 50-year-old that really want to work hard. It's hard work. And so you have that sector that you have to pull out too. So it's some challenges. One to educate. It's another challenge to identify. Do they know what's out there? So you make sure they know what's out there, make sure they know what's available, help them get there to that select few that want to, and then you help them get the jobs at one of our places. And we all have them. I mean, whether it be me or Donovan or Barry or the countless other ones, they're out there, and we all need them today. Trust me, all of us. But identifying those, helping them get there, and then creating the programs that can add for that training it's important, and I think it's getting better, but it is still a challenge.
Yeah, I think to add to this, KCTC's overall enrollment decreased during COVID, and it's gradually going back up. But in the same token, there's not as many people out there going to school and wanting to be trained and to be trained. And we want to blame everything on COVID, and a lot of it is true. But ever since COVID, we had a lot of long-tenured people that got out of the industry. And there is not a pipeline of young, ambitious people that want to replace them. And I think before COVID hit, all of the social media, the remote working, things like that was creeping into a more lackadaisical work efforts. But COVID really crippled it. And I'm okay with saying that because, we witnessed it. Remote working is good, but it has hurt us tremendously. And so I really feel like that's part of the problem is, people just don't want to come back to work.
I tried to birth and raise all my own nursing staff. It just didn't work. Couldn't get them fast enough.
Yeah, nine grandkids. Yeah,
9 grandkids. All my kids are nurses. All their spouses are nurses, but that's only 6. So.
Well, Barry, you mentioned substance use disorder, and we have a population that justice involved population or may have something on the record. I mean, can you guys talk about for maybe those folks that are trying to come back into the workforce? I'm imagining there's maybe more challenges in healthcare given the type of work and liability concerns. Is it becoming easier, or is anybody looking at those folks being able to potentially come in and do more, or is that still just hard for you guys to manage?
No, I think in the past the stigma really prohibited a lot of second chance the second chance workforce. However, I think in today's world, the desperate need for work, for manpower, and also the willingness to forgive. And I think it's being more accepting to give people second, third, and fourth chances where it wasn't before. And even the Kentucky Chamber has got a training mechanism for employers that want to employ second chance employment. And so I think it's becoming more and more accepting.
Right. Yeah, that and we all, I'm going to bet every single one of us in here have been touched by substance abuse at one point or another. I mean, so we all have a relationship to it. So you're a little more easy to accept it because of that too.
There is more of a tolerance to it. And then the other thing that we're seeing that we should be very thankful for in Kentucky, and I know Colby Soar has been a part of this because of partnerships, but when you have organizations like ARC, River Place, and having those facilities that put parameters in and requirements and really preach a second chance allowed us to make different policy changes. So, everybody's looking for skilled labor or unskilled labor at that point, depending upon what position you're looking for. So taking somebody out of a River Place in Pikeville and putting them in as an EVS worker just makes sense for second chance. But we've gone above that. It's not just those that are dealing with recovery of drug addictions in some sense, but it's also we've made exceptions for people who are pursuing their GED. That we can continue to help advance and find and pave a way, because it benefits the community, it benefits them as well. And there's some other things that we're all doing and looking differently than we did in years past. But I think organizations, well, I know, having a relationship with organizations like ARC are changing minds. It's opening opportunities. It's creating a pathway for second chance, and it's simply the right thing to do.
Let's go back a little bit to the payer mix conversation that you guys started. So I guess, what's an ideal payer, how does the payer mix here compare to other rural parts of the country? What's the ideal payer mix you're shooting for? And then how do you get there? I mean, I get that there's a need for and where I'm going with this, right, is
What am I shooting for? 100% commercial.
Yeah, that's right. I get that. So, but to get more private insurance, right? You need more industry. You need more private employers. You need that type of growth. But where I'm coming back with this is, at the same time, though, does that just exacerbate the workforce challenges? So, on one hand, you guys need more commercial, insurance, more private insurers, more employment. But then, how do we, I guess, get not to worry about the problems of tomorrow, but then how do we prepare for the inevitable situation of then, if that happens, then it's the workforce challenges become even worse?
I think on this hand, we all, all of us, work on workforce development, trying to bring other things into the community, knowing that we will have more folks, number one, and then more jobs, number two, and they'll all basically be insured, which is great too. We all working on this end, on the case mix side of things, or the payer mix side of things. On this side of things, we work with the legislative board. How do we get the pay structure better? Because we think we can affect that greater. I have a better chance of affecting that than affecting this side of things. Only because this side of things is the long-term goal. You know, we'll get there. We can bring more folks in. We'll get more business in. We'll get more things in. That's a more long-term stretch. That's a 4, 5, 6, 7, 8 year, 10 plan. This legislative side, you work hard enough, you might get it this year. I mean, it's, you know, you'll at least get bites and bites and bites. Bad part is this long-term plan is truthfully a long-term plan, right? It takes longer to get it, but then it's here and it's going to stay, and you get it forever, or not forever, for a longer time. The legislative side, I'll get it, but I'm just going to get it this year. And then I got to fight again, get it next year.
Colby, the answer isn't easy. It really isn't, because it is difficult. So you bring up an interesting point, but if you look on top of bringing in new business, you also have to look at the out-migration. So we're losing population, right? Inflation has hit us. Our payer mix continues to go up, more Medicaid, Medicare driven. If you bring in new business, and we kind of had actually some of these discussions with the local government recently in trying to develop, or looking at developing more retail sectors. So you lower the wage when you go into more retail, and you drain the workforce even more so when you go into more retail, even though everybody wants those services, which is needed to attract physicians and others into the market. So there isn't really a real good answer to this. It is long-term planning. It is making smart investments, but it's also stopping the hemorrhaging now. And that's what I think we need, from our perspective, we have to focus on, is that what can we do today? Because, it actually dawned on me earlier as we were talking about what the purpose of today's event is that we all know that there is needs even in healthcare that we want to expand upon. But almost on a given day, we have to decide where to shift those dollars, just because those dollars are not what people think they are. So if you look at, and we were discussing this earlier, there's a lot of services that people don't realize that we offer that are lost leaders. We lose money on them. So when you look at specialty care specifically, subspecialty care, that these are, they're lost leaders for the hospital, clinics, but they're the right thing to do to serve our people and to make sure that we're providing a quality of life. So, we take things like cancer and heart and orthopedics and those things that tend to have a better payout, to be able to provide services like endocrinology and rheumatology and those things that keep people from traveling for 3 hours, because it's the right thing to do. And the same thing is, and hospitals look at it and appreciate organizations like Barry's that do a phenomenal job, because the referral business is also very important to keep services so that patients can stay home, because that's part of the holistic healing process of being able to have support around you. But typically, you asked the question a moment ago about how Barry looks at combining services so that you don't have additional resource burn. Because the fact of the matter is that organizations like ours, because of the reimbursement, we put a clinic out somewhere, because of the resource burn, it's automatically a huge loss to the hospital. So we rely upon FQHCs and organizations like Barry's that are in rural to form these relationships, that do a phenomenal job at what they do as well, providing that level of service. So again, this is I could give you a much longer answer, but it's a very, very complicated business to understand.
And as far as reimbursement is concerned, we mimic the hospitals about 77, 78%, Medicaid, Medicare. For us, when we use commercial insurance, it used to be a really good payer, but now for clinics and for physician offices, they have not increased rates. However, they have increased premiums. So if you use Anthem to cover your employees, they may increase your rate 15% for your premium, but they leave your reimbursement at the same rate. So actually, we're fighting against that. So to me, I would rather have, at least we get a 3 or 4% increase with Medicare and Medicaid. I'd rather have 100% Medicaid and Medicare.
As long as it wasn't managed.
Yeah, as long as that's not managed. Well, the way it is managed now.
Yeah.
So I guess, it just kind of really depends. And but as far as the reimbursements, it could be worked on for sure.
And do you hear, Colby, and you're going to hear this no matter who you put up here, what hospital or clinic, you're going to hear the same exact comments over and over and over. Because look at the state of where we are as a nation and as a state, and when we look at healthcare. Our Medicare costs, CMS, I mean, it's a huge part of the federal budget, of which they're under scrutiny right now as well, which we get that. When you look at rural health, the things that we're fighting within our own state that are frustrating. When you look at CON, we were talking about what's been going on over the last couple of years with the CON debate, which is absolutely ludicrous, in order to protect rural health. Because by cutting out or doing things with the CON that's adversary to hospitals will diminish services, which means people travel, which means people candidly die, or they don't seek care. And then you throw on top of that what we're facing with inflation, with workforce crisis, and then heck, we'll look at even tort reform. The amount of, look at Kentucky, of what the millions of dollars and millions and millions and millions of dollars that are spent because of the malpractice insurance. I mean, these other states don't have to deal with. It's on top of trying to take care of the sickest of the sick and the poorest of the poor. So when I say it's a complicated business, it truly is a complicated business with what healthcare has came out of COVID that we're having to fight almost daily. And to the point we get through an issue and it's like a boomerang. It comes right back the next year, and we'll spend an absorbent amount of time trying to protect rural healthcare specifically, but more importantly, trying to protect the families that we serve.
And also with the reimbursement, the percentage increases, that's not even touching the higher deductibles. Who has not been touched by higher deductibles over the last 4 or 5 years? I mean, when you look at that, that forces you as a patient to pay more for your health care. So you may end up paying more with your payroll deductions, but you're also paying more out of pocket because of the deductibles are increasing dramatically.
Well, last question here, kind of bringing it around to the event today focused on diabetes and chronic conditions that we deal with, Donovan, the comorbidities. And we've talked about all these complicated factors that go into the business that you're in. And so can you mention or talk about kind of the role that providers, whether it's primary care or whether it's hospitals, in reducing the amount of chronic conditions? I mean, is it shifting incentives? I mean, what type of policy changes? I mean, ultimately, I think everybody here would agree we want people to be healthier. We want people to have less amounts of diabetes, which means we need to treat less and prevent more, which is what Dr. Stack talked about. So how do we get everything to where it's in the best interest of you guys, it's in the best interest of patients, it's in the best interest of MCOs, and ultimately we're all around this common goal of reducing. And then to Donovan, I mean, what does that mean? And I'm say Donovan, but I'm looking at all three. But when people are healthier, when your own employees are healthier and they have reduced rates of this, I'd imagine that's good for your bottom line as well in terms of, or it's good for the financial health of your institution in terms of what you pay for your own health care, right? So I'd imagine there's some other benefits, but kind of bring it back around to how we all win here.
Again, Colby, there's no easy answer to this, and I'm sure we're all going to have some of the same issues. If you look at, the standard issue, it's always going to be offerings and reimbursement, education, services, testing, all those components that need to be. But we also have to look, I mentioned specialty care when you're talking about specifically what we're here today talking about. We have to also realize there's a subset of people that through education doesn't matter, they're going to be sick. and that the need of things like endocrinology and ophthalmology and rheumatology and all those things, they have to be here to be able to address and to support. If not, then your community is going to continue to battle these illnesses. It's going to continue to force cost up because people are going to delay care. If delays care, it costs more on the back end than it does on the front end. So offering incentives, working with CMOs and like patient reward opportunities to kind of force almost a well-check program. So as a child's in a program, you can actually diagnose them sooner and earlier, and so it doesn't become more of a chronic condition that again has additional cost. So these are all complicated issues that, to your point, are going to require the CMOs, the legislators, the administrators to kind of all sit down to look at how we win as not just a state, but as a country, because these are problems that are being faced all across the U.S. right now, that until that there is a plan and change, they're not going to get any better. They really aren't.
So with this issue with diabetes, I mean it becomes mission driven, right? I mean without even knowing their mission, I'm sure it's similar to ours. When you're talking about improving the healthcare of the community, the healthcare Appalachian, diabetes affects every other industry that we have, whether it be obesity or heart disease, or you just go down the litany of lists. So by treating and eradicating or nearly eradicating this disease, it helps to funnel into the issues that we have that affect all the aspects of care that we provide, whether it would be heart care and the cath lab, or whether it would be primary care and the things that Bayer can provide here. So part of the true answer to what you're saying, all this becomes mission driven, and if our mission is to make communities healthier, or whatever our mission is with these fellows, it all boils down to whether we buy in and agree to our mission or not. So when we do buy in to agree to our mission, and we do these things like the symposiums, or we do these things like education efforts, or the things like Dr. Stack is talking about, preventative care and not treatment care. We all have to do these things, and when you hear these things at these symposiums, it's about whether you take this knowledge that you have and you keep it internal, or you take this knowledge you have and make it external. So all the things that you've learned today, if you take this out and you spread it, whether it's through your job or through your home life, that's where that starts to make a difference. We can only reach so many people. So we have to rely on everyone that's in here to reach those people, and then the people you're teaching to reach those people. Are we all going to become professionals in diabetes? No. Some of us are. Some of us are not. But we all can help spread the word and really help funnel those people to the people that do know.
I think having available services and educating the patients and having the MCOs and the governmental agencies and the commercial insurance companies to be on board with, working together and not working against each other. And I know no profit, no margin, no mission. But in the same token, nobody can ignore the fact that insurance companies are making a lot more than healthcare organizations. If they could help us, invest more money into patient care, patient education, I think that would be a major win. And I know I'm going to get bashed for saying that, but it is true. But I really feel like having good partnerships like we have, that's a huge start. Now, if we can develop those kind of partnerships with the insurance companies, with Medicaid managed care organizations, that's the next step, that we can all buy into the same vision and the same outcomes. What is the best outcome for a diabetic patient? And that's, overall health. We use A1Cs as a great indicator, and it is. But it's, when you look at a diabetic patient, the biggest portion of their lifetime expense is in the last 2 years of their life because they're battling to stay alive. If we could work on that and be able to work on preventing and curbing diabetes, COPD, obesity, we're going to be able to take small links out of that chain, because that chain has become long over the course of years, and we're not going to be able to do anything sweeping to fix it. But I really feel like more buy-in by the people that actually controls the dollars is going to be key.
Yeah, you've got to, what Barry's saying in a kind of ways, you got to get special interest out of it to a degree, and you got to do the right thing, and you got to get those that are elected that are making these policies and decisions to understand what this really means to regions like ours. You know, it is a travesty, Barry, to your point, when you look at the bottom line of an insurance company, and you look at our bottom line. When you look at last year, 95% before HRIP, 95% of the hospitals in Kentucky were losing money. We're in the red. 95% of the hospitals in Kentucky were losing money in the red. If HRIP goes away, it's going to be right back in the same position. All hospitals? Yes, all hospitals. But then you look also at not just insurance companies, but I just got a text on my way in from the American Hospital Association talking about the new guidelines coming down for 340B. You know, that's another example to where look at what Big Pharma is making on their bottom line, but they're fighting us tooth and nail every chance they get with special interest, trying to lower those payments that directly come back to the rural communities, in essence, support them. So it's opening up good dialogue, getting good information, educating those outside of special interest as of what this really means. Because at the end of the day, what this means is about saving lives of the people that's built this country in the rural part of America right now. You know, it's sad when we see. You know, we were talking before we came up, when you look at a child because next, and I won't pick out the school system, but talking about school system, closed down for 2 days because of the election coming up, closed down Monday and Tuesday, when you know that a child is going home unfed because it's 2 days they're going to miss a meal at school. And it's a shame that we're in these kind of conversations at this day and age in our own country. Healthcare is no different. And trying to provide services, again, to the region that we provide. We're not asking necessarily for a handout. We're asking for support and doing what's right and distributing the wealth in a way that benefits those that are in the greatest need.
Well, thank you all for being up here and sharing your commentary and thoughts. And yeah, we just really appreciate you being there. So let's give it up for our panelists for this discussion this afternoon.